Okay, good evening, everyone. Welcome and thank you for joining AAMS Journal Club tonight. I am Nora Gashi, President of Albanian American Medical Society. This is our 7th Journal Club since we started. I'm so glad everyone is joining us. I'm happy to see all these Albanian healthcare professionals participating and presenting in our Journal Club. We will continue to organize this, and please, I encourage you everyone for feedback. And if you have any new ideas for Journal Club, please send us suggestions and we are more than happy to organize it. Tonight's article is Gastrointestinal Symptoms Associated with COVID-19, Impact on the Gut Microbiome, published December 2020. Our presenters are Dr. Bjerona Shaipi. She received medical degree at the University Clinical Center of Kosovo, Pristina, working towards her goal to be ECFNG certified. She's also AAMS internal coordinator. Then Dr. Erdiana Ojallari graduated medical school from Michigan State College of Human Medicine in 2020. She's pursuing her career in trauma and acute care surgery and fellowship in surgical critical care. And the moderator tonight is Dr. Uli Zhubi. He is a colorectal surgeon, member of American College of Surgeons, and member of the American Society of Colon and Rectal Surgeons. He's currently practicing in Greater Phoenix, Arizona area, and it's his first year of practicing after training. Bjerona,
Yes.
I think it's your turn.
So I'm trying to share the screen, but it doesn't let me. Jürgen?
I can share your presentation if you want.
You're good now. Yeah, if you tried, you're good.
Okay. A second.
I gotta learn. Okay, go.
And so hi everyone. I'm really happy and excited and nervous to be presenting. So without losing time, I'm gonna jump. So today journal topic is gastrointestinal symptoms associated with the COVID-19 impact on the gut microbiome. So just a brief overview of the COVID-19. SARS-CoV-2 is one of the greatest worldwide pandemics since the 1918 flu. Coronavirus are envelope-positive sense RNA viruses. Their diameters ranges from 60 to 140 nanometers with a spike-like projection on its surface, giving it a chrome-like appearance under the electronic microscope. And as we all know, that's how it comes also the name coronavirus, which in the Latin word, corona means a crown. SARS-CoV-2 primarily attacks the respiratory system as it represents the main point of entry in the body. The severity of COVID-19 is combined with a set of comorbidities such as hypertension, diabetes, obesity, and advanced age. And all these that seriously exacerbate the consequence of the infection. SARS-CoV-2 also can affect gastrointestinal system with the symptoms as vomiting, diarrhea, abdominal pain during the early phase of the disease. Spread and prevention. Unlike the other coronaviruses, SARS-CoV-2 infects people and leaves them with a few or no symptoms at all. It has a very strong transmission capacity via respiratory droplets. And despite this, even people that present positive with COVID-19, but who are asymptomatic, they still can spread the virus. So the initial method for restricting the virus transmission has been to advise people to practice social vaccination, which means limiting social gathering, minimizing public appearances, telecommunicating, and wearing masks as much as possible. In the US, were 184 million cases with a total of 3.98 million deaths. And as far as now, vaccination is one of the most effective methods for prevention of the COVID-19 in the future. And as of 5 of July, 2021, a total of 2,988,941,529 vaccine doses have been administered. So the objectives of this review studies to see if the SARS-CoV infection has been connected to gastrointestinal alteration, is linked to COVID-19 phases associated with inflammation. The restoration of the gut microbiome of people infected with the SARS-CoV-2 could lead to a new treatment intervention to reduce systemic inflammation, intestinal damage, and the efficacy of the virus. Early and late stages of the infection, it was seen that when symptomatology of the disease does not express itself with respiratory symptoms, person tends to be more infectious in the early stages, and pre-symptomatic transmission may play an essential role. In a study of 102 COVID-19 patients, blood levels of cytokines such as interleukin-6 and interleukin-10 were used as a marker of the disease severity, demonstrating that high levels of pro-inflammatory cytokine storm were linked to more severity disease progression. COVID-19 caused significant problem in certain patients, like respiratory distress syndrome, cardiovascular disease, or any organ dysfunction syndrome, and septic shock. And all these problems were linked to cytokine release and hyperinflammation, as known as a cytokine storm syndrome. Clinical presentation in those patients that present with the GI symptoms was mainly with diarrhea, anorexia, vomiting, and abdominal pain. All this as a consequence of compromised intestinal barrier integrity and gut microorganisms stimulating innate and adaptive immune cells, which cause pro-inflammatory cytokines to be released in the circulatory system, resulting this way in a systemic inflammation. Systematic meta-analysis demonstrate an incidence rate of diarrhea ranging from 2% to 50% of positive patients. And the people that had GI symptoms tend to have more severe and prolonged manifestation of the disease. The viral load of coronavirus appeared in the feces of 54% of the infected patient. And this is one of the facts that made researchers do a new question: is there transmission of the coronavirus found in the fecal samples? And one of the interesting facts is that the SARS-CoV-2 shedding is detectable in feces samples for a longer period of time than it is on nasopharyngeal swabs. And calprotectin measurement could play a potential role in monitoring the disease of the patient that manifests with the GI symptoms as they were very increased. SARS-CoV-2 and ACE2 intestinal receptors. SARS-CoV-2 enters to the body basically by binding to ACE2 receptor and TMPRSS2 receptors. And it mainly binds to the protein S of the SARS-CoV-2. And as it binds, it leads to an inflammatory response and gut microbiome dysbiosis. Also by altering the T and B cells, which lead to transmission of the infection into the circulatory system, brain, and all the other organs. And early phase of the COVID-19, it tends to be more with intestinal dysfunction, and the inflammation is not very high. But as the phase progresses, we see a decrease of the intestinal dysfunction, and respiratory distress syndrome is high, and the inflammation, all this due to cytokine storm. The effect of COVID-19 on the gut microbiome. During the hospitalization time, the following were detected. Bacteroides dorei, Bacteroides tetatomicron, Bacteroides macillensis, and Bacteroides ovarus, which downregulate the expression of the ACE2 in the murine gut, correlating inversely with the SARS-CoV-2 load in the fecal samples. And as far as all of the studies, it was seen that the gut microbiome remains substantially different in hospitalized patients from that of healthy control. Comorbidities, SARS-CoV-2 can infect persons of all age, but it appears that it tends to affect more severely older adults and those with the prior medical issues. There are numerous theories of this, why it might be happening, but mainly is because of the loss of the microbial diversity and the heightened vulnerability to inflammation as we age, because we all know that the gut microbiome changes throughout the time in humans. Also, obesity is one of the highly risk factor. It was present in 25% of the COVID-19 patients who died in the United States, making it equivalent as a risk factor as a cardiovascular disease with the same high risk population as 21%. Obesity is linked to alteration of the gut flora and is a risk factor for COVID-19 severity. And it makes it as a comorbidity in both adults and children as well. And all this as adipose tissue tends to be as a reservoir for SARS-CoV-2 transmission, viral clearance, and systemic immune activation. Obese patients' adipocytes have a greater ACE2 level, and as we talked before, ACE2 level is one of the main entry point for COVID virus in our body. Also marked this regulation of myeloid and lymphoid response within an obese patient's body was observed. Diabetes is also linked to an increase in the severity of COVID-19, and this can be attributed to systemic inflammation and gut metabolic abnormalities. And cardiovascular illness is one of the risk factors as well. An imbalance of gut microbiota and the reduction in microbiome diversity are associated with a cardiovascular disease. Diet change to manage COVID-19. So according to multiple studies, a good diet and the nutrition are very important and required for an optimum immune response to control SARS-CoV-2 illness. And high quality protein helps because the synthesis of antibody requires an amount of proteins. Also, vitamin A and zinc deficiencies has been linked to an increased risk of infection. So the diet with a high vitamin A and zinc could help. Branched chain amino acids as well. Omega-3 fatty acids with a high anti-inflammatory and antioxidant capacity, vitamin C, vitamin E, and phytochemicals such as carotenoids, polyphenols that are widely present in plant-based foods. Vitamin D in the diet could be adjusted to enhance the immune system, and in a study of the elderly males found that those with a pre-existing illness and who had a low vitamin D levels were 13 times more likely to die due to COVID-19. Fiber consumption caused a decrease of in range of 20 to 40% risk of mortality from infectious and respiratory disease and the chronic obstructive pulmonary disease. Consumption of whole grains is also associated with a more favorable microbiome composition, which reduces the intestinal and systematic inflammation, and has been linked to a decrease in the CRP, IL-6, and tumor necrosis factor alpha. Gut microbiota-based approach to reduce severity. Healthy gut microbiota is rich in Bifidobacterium specia, Faecalibacterium specia, Ramonococcus specia, and Prevotella specia. The use of prebiotics and probiotics prebiotics and probiotics to balance the intestinal flora may be a useful treatment to reduce bacterial and viral infection, but however, this does not tend to reduce the symptom severity or hospitalization time. But if we use a good mix of prebiotic and probiotics, it may cause the disease severity to be minimized. Conclusion. So despite hundreds of publications and all of this COVID-19 research that has been going on the past months, there are a lot of unanswered concerns concerning the disease and successful treatment technique. As a result, identifying the symptoms and stages of the infection is a difficult but a vital effort in order to stop the spread of the sickness. Intestinal symptoms should be monitored and altering or engineering intestinal bacteria or their metabolic products in response to COVID-19 could be beneficial treatment options. Thank you.
All right, Verona, I think you did a very good job of summarizing the article. As a colorectal surgeon, I don't see a lot of patients with generally just GI symptoms from COVID, but I've heard of them in speaking to my colleagues, especially the GI colleagues, and diarrhea and sort of nausea, vomiting were at the end sort of diagnosis of exclusion to make sure that nothing else was going on with these patients. I think this was a good study to summarize everything, especially with the gut microbiome and what goes on there. I was surprised to myself learn about how in some patients, they're having GI symptoms, meaning that they're most likely swallowing the virus and it's getting into the intestinal tract and before hitting their respiratory system. So that is something that I think needs to be examined further and see how we can change that potentially through the gut microbiome, these probiotics they're talking and prebiotics and even can you change the gut microbiome through a fecal transplant, something that we do more often nowadays for somebody with recurrent C. diff, for example. I think is there again here? I think
Can you hear me?
Yeah.
Hey guys. So adding a little more to the prebiotics, probiotics. So we saw a handful of patients who presented just with GI symptoms. So they had no respiratory symptoms. They come in abdominal pain, diarrhea, and obviously everybody who came in, we tested COVID, and we had about 15-20% because we kind of did a little collection of patients that we were seeing. Even though I'm in a community hospital, I mean, we're getting 300-400 patients, for like a couple of months, and so I think we're seeing about 15% of the patients with COVID, we're seeing that are just presented with just GI symptoms. And nausea, vomiting, abdominal pain, diarrhea, that's pretty much the symptoms. Never had to do an endoscopy for these cases. A lot of the times we just, it's just supportive care, just as you would treat any nausea, vomiting, abdominal pain. There's one case where actually there was rectal bleeding. So he actually caused somewhat of ischemic colitis from COVID. At least that's what we suspect that it was. But the role of prebiotics and probiotics, actually the new guidelines just came out from AGA guidelines, and they're barely, I mean, they're not really recommended in any specific cases unless you're taking antibiotics. Then they recommend probiotics, or we use them for pouchitis. We use the VSL number 3 probiotic, and then otherwise in children for this enterocolitis. But for general use, they say it's not recommended, but they'll defer it to the population if they want to use it. So there's really no, this just came out this year. So there's no good data about prebiotics, probiotics on COVID. But yeah, the gut microbiome is becoming a big thing now for everything. IBS, C. diff, you name it. So we'll see what's gonna come out to a lot of that. But Yeah, I mean, that's the thing with COVID. A lot of the times too, this article was very kind of pathophysiology, but we've seen a lot of elevated liver enzymes, acute hepatitis from COVID infections. So we saw a lot of patients who just came in with no other risk factors, COVID positive, acute hepatitis. A couple of patients with liver failure, but they had underlying cirrhosis. So I mean, it's kind of it hit everything. I mean, it's just one of those things where it sucked.
Um,
But
the sorry.
now you're good.
The reason I picked this article was because we had quite a handful of patients come to our hospital with pneumatosis. And
Yeah.
if everybody's familiar with that, we learn in med school, it's a surgical emergency. There's, air in the bowel wall. And one patient, just because of the severity of their pain, we took for a diagnostic laparoscopy, and there was no ischemic bowels, just benign. So we chalked it up, and they were COVID positive. So that's kind of what we chalked it up to after we ruled out ischemic bowel. No other medical history really. And then we had, 5 or 6.
Was it true pneumatosis or was it an overread?
It was. No, there was
Okay.
there was pneumatosis. It was just there was no ischemic bowel, and we had maybe 5 or 6 more of those within a couple months.
Yeah.
So at that point, if they were COVID positive, we had that finding, we were a lot more careful about taking them directly to the OR, just
Right.
basing, lactate, serial labs, exams, things like that.
Right.
That's why I just kind of wanted to see, if there's a correlation, but I wasn't able to find anything for pneumatosis specifically.
Yeah. Our main issue was, a lot of patients with IBD, obviously who came in with a flare, and I was like, is it COVID? Is it a true flare, or is it from COVID, or it's kind of like, so that's where the calprotectin, when they mentioned, comes into effect from our standpoint. Obviously, if it's, we didn't see much elevated calprotectin in just, normal COVID diarrhea, but with IBD patients. And steroids was a big thing. I know they used dexamethasone to treat severe, COVID and ARDS and stuff like that, but our GI guidelines said against the use of any prednisone if we really had to in like UC cases. But other than that, we barely use prednisone. We'd use budesonide or try to switch them to azathioprine or Remicade or stuff like that. But they it was really tough. Kind of like if they have a flare, usually we put them on steroids to get them through the flare. Now it's like, well, it's like what and budesonide is so expensive. It's like, what do you use?
That was another issue we had too, because if they our hospital started doing, if they have COVID and they had some sort of respiratory symptom associated with the GI symptoms, they would put them on steroids, but then we take them to the OR, and that's clearly not
That's all right.
giving
Won't
steroids.
heal it, right? Yeah, it's tough,
it was
but
between a rock and a hard place kind of.
it's a nasty virus.
Yeah.
And we're still continuing the biologics, correct?
We're continuing the biologics. Vaccines
No
were
reason to
safe.
hold them back.
The only one we hold is like the tofa, the new biologic, the tofacitinib, the oral antibiotic, the oral one. Otherwise, once you get the other ones, I mean, you're at least, once you get a dose. Yeah, I've started patients on Entyvio and Remicade, but the tofa one is just a different agent. They usually will hold that for like 5 days or something like that, because that's an everyday medication.
Tofa, out of curiosity.
I'm sorry?
Why specifically do we hold tofa?
I don't exactly. Yeah, I really just whatever the guidelines say. I can look it up and get you back to you next time. But they just recommended it just to. I don't know if it was because it was just an everyday medication or the way that I'm not because everything else is just every 8 weeks or 4 weeks or whatnot. So at least there's a big there. But tofa was definitely they recommended at least holding it for 5 to 7 days or at least until symptoms got better. Just because maybe increased risk of I'm not I really that I don't know.
Is it maybe a organ?
Yeah.
Because we're dealing with in my hospital we didn't have a ton of GI emergencies, but we had a couple of COVID patients get colitis.
Yes, I've seen that. Yeah, I've seen that many times. A handful.
So ischemic colitis was not quite the scenario that we were foreseeing. But what we saw was basically they recovered when they COVID got better. Basically, their colitis better as they're being treated with, all the, the new monoclonal antibodies and stuff like that they started giving them. But they, thank God, knock on wood, we didn't have to take anyone emergently to the operating room to do anything for it. But talking about, the whole surgical, principle for this, when you see gas in the bowel wall, as Dr. Jalari mentioned, it's a very scary picture. I've learned over the years that, seeing a CAT scan and seeing a patient makes a difference. I've had patients with pneumatosis in the past that, I'm calling the OR, getting them ready, and then I go evaluate the patient. I'm like, oh, no, wait, hold off. We're not going to the OR. And some of the issues with COVID related, GI symptoms is that just like a huge curveball. Now, what do you treat? We can't get rid of the virus. So
I mean, you don't. I mean, that's the thing. You don't. You just it's symptomatic treatment
Yeah.
in any ways. I mean, it pretty much is just like any other virus. I mean, you get hepatitis in a way. If you look at that way, you get hepatitis A, B. Acute hepatitis A or hepatitis B, you're gonna have the same viral symptoms. You still have the fatigue, nausea, vomiting, abdominal pain, diarrhea. So in that aspect, I wasn't surprised that this virus is causing GI symptoms. But I have seen a couple of cases. Again, one was a nasty colitis that I was questioning. I was like, it has to be. I was like, it's got to be COVID or whatever. And there's a couple of case reports that had, definitely presented with rectal bleeding. Obviously, we tried to avoid scoping, as much as we could, unless it was just like GI bleeds, emergencies. But this patient I did have to scope, and it was a pretty nasty colitis. But it did, as you said, it resolved after COVID. It resolved in a couple of weeks, just self-resolution without any medications.
Mm-hmm.
I just put him an antibiotic just for translocation to prevent, for ischemic colitis, just to prevent it. But other than that, I was like, you don't treat. I mean, what do you treat exactly?
Yeah, exactly.
But one of those, yeah. But yeah, I mean, this article again, when I read it, I was like, okay, it's a lot of pathophysiology, but it's affected a lot of the symptoms. It's affected a lot of the. Which one did I have? The last one. That one almost had acute liver failure, and then he resolved, improved just again kind of supportive care, but nothing that we were giving him. And that's been a couple. I just had a female patient, 56, who came in the office the other day, and this is not from COVID, but she had the second COVID vaccination, and she presented to the dermatologist with a rash. He did a skin biopsy, and her liver enzymes are in the 300s. So
Wow.
I'm like, okay. She's like, that's the only medication she's like, she's not on any medications, no herbal, nothing, no drinker. And then we waited for the liver biopsy. I did liver workup for autoimmune hepatitis, stuff like that. The skin biopsy came back for drug-induced rash. So we kind of blame it on the vaccine. And of course, I looked up. There was a couple of case reports associated with, acute hepatitis and this rash from the vaccine. So it's like,
which one was it? The mRNA?
she had a Pfizer.
You had the Pfizer?
Here's the Pfizer. Yeah, she had it like 3 or 4 weeks ago. Yeah, she had.
That's strange because it's not like a systemic type of medication.
That's what I'm saying, right? It doesn't act the same way, but it's weird. I mean, it's like, yeah, it's always something.
You give it to enough people, something will happen, right? Did you
still,
any
that has a peg allergy, potentially. I mean, that's.
But it's crazy. Why only after the second dose? Though? Yeah, this was the second dose. First dose, she was fine, but this was after the second dose, which didn't make any sense. And again, I mean, she denies any other thing, but you have two things where you have a acute hepatitis and a drug. So I'm like, it has to be that. I mean, it just, and it resolved. Of course, it resolved after 2 weeks. I put her on some low dose prednisone, and then everything got better. So it's like.
Any long-term issues that anyone has noticed on some of these patients who, develop GI symptoms with COVID, like diarrhea that's not responding to treatment, or?
I mean, you'll always have that 20% of patients, mostly female, who'll develop the post-infectious IBS. So it's common with any other infection that we see, and then we treat her from IBS standpoint. But I mean, nothing that I've seen, they're like, oh, I'll come back. But mostly, definitely IBS is is more common after an infection like that.
I recently saw a patient for not related to what I was seeing him for an anal fistula and did a fistulotomy, and then I was just posing the question of potential fecal incontinence after a procedure that we do for fistulotomy. That he complained that ever since having COVID, even before I operated on him, that he had increased urgency, and sometimes he is having diarrhea. So I just recommended that he bulk up his stool with fiber and
CGI.
It's like, you know, whenever we get a roadblock, fiber is always the answer.
Right. Yeah, I see my surgeons there, right there, fiber, 35 to 40 grams of fiber a day.
Always.
So again, when you did the colonoscopy on that patient for colitis, what were the findings?
It was diffuse pain colitis. I mean, it did not have the appearance of, I mean, it looked kind of like almost, there was a few necrotic areas, but it looked like ischemic colitis, but it was diffuse. So, I mean, it's not the typical pattern of ischemic colitis, you know, it's sigmoid, descending colon, transitolar, splenic flexure area. And this was diffuse. It was just like, man. And I've seen one case like that from E. coli. This was last year. So it looked the same way, but all these other stool studies were negative.
Right.
And then I think, but he resolved literally with like 6 weeks. I scoped him back and, you know, I put another scope in him like 2 months and complete resolution.
What was the treatment? Nothing?
I just left him on, it was just antibiotic we just prevent, you know, when it was just severe, it's just to prevent, we don't treat, but just to prevent translocation peritonitis, we just put him on ciproflagyl and leave it on that just for, you know, 10 days, but no treatment. I mean, everything else, supportive care. And that's the main thing that we do, especially when they're in the hospital, we load them up with IV fluids to prevent something like, because there's some, obviously the reports of, you know, prevent ischemic colitis from just hypertension and stuff like that. But yeah, it's really, I mean, we haven't,
I mean, there are a lot of cases with GI symptoms. I have a few cases with GI symptoms, and they were mostly elderly because they were dehydrated. That's why they presented in hospital. So who knows how many outpatient settings that there were GI symptoms. Yeah.
But on the outpatient, they're calling us from new onset symptoms, and that's what their recommendations are now, or before, whenever this was worse. They were saying that, you know, if somebody as an outpatient presents with new onset GI symptoms within 48 hours, check COVID. Anybody in the hospital, same thing, new onset symptoms, check COVID. And that was, I mean, then you would see when they get the CAT scan, because they get a CT abdomen, but then you see the lungs, they have, you know, pneumonia, COVID changes from the lungs, but they only presented with, you know, GI symptoms.
Yeah.
So that was very common to see.
Yeah.
And there's always the difficulty sometimes when they come to the ED that they have these symptoms, but then, you know, somebody else has been sick or they ate something, and then you don't, you know, what's the cause? Do they just happen to be coincidentally COVID positive, or is it because of COVID? So I think it's kind of hard to really study it.
Did you do by any chance? Did you do a biopsy on that colitis patient?
I did not. Okay. I mean, I saw it. I'm like, okay, this looks like. I'm like, I did not. I didn't think it was UC. I didn't think it was Crohn's. I'm like, okay, stool studies all negative. I'm like, it's got to be COVID. And I had seen a few case reports. I'm like, okay, it has to be at least just case report written. But I'm like, you know what? Just the way I looked, I'm like,
PCR on COVID.
If we're what?
Are you guys doing a stool test for COVID now?
No, I don't think I've ever. No, I don't think we have it. At least, I don't think I've never ordered it.
My husband doesn't have it either, but that would be the way to test it, I guess.
I know they shed it, right? Exactly. I know they shed it, but it's like, never had it.
Was that presentation saying that 52% of patients have a positive COVID virus?
They have they have shedding, yeah.
Yeah, they're shedding,
They're shedding it, right.
Interesting. I don't know how accurate it is.
Well, think of it, it's coming both ends, right? They're breathing, they're coughing, and it's coming out the other end too.
Yeah, I mean, it was surprising too for us. I mean, we're waiting N95s and all the stuff like that too, but they were saying obviously we're more during EGD, but then yet you read all this stuff that you're shedding it more during the stool. So I kind of like, you know, just leave it all the whole time.
Well, there was shedding, actually, there's a report of shedding during laparoscopic surgeries just from the OR smoke. We had a whole protocol in our hospital about doing things like lap appies and gallbladders with a filter, because we didn't want, or I guess the idea was to catch whatever the viral particles coming out of the OR smoke.
So at our hospital, we stopped testing for like routine surgery, choles, appies, things like that. They're vaccinated. So if they have proof of vaccination, they won't get tested. So then, we still don't know if they have any other variants, and now we're all exposed to it. So I think we're testing less now that the vaccines are becoming.
Right. Yeah. Same here. Yes, our hospital just changed their guidelines too. So if you're vaccinated, you don't get tested. But we still we the good thing is we tested from yeah. I mean, there was a couple of like 3-4 weeks we didn't scope at all. Actually more than 3-4 weeks. It's like a couple of months. Yeah, we didn't scope. We barely scoped. And then after that, we started testing everybody. So at least they're getting tested. At least you're still protected. But now, our guidelines say now you don't need a test. Some hospitals were not testing at all before any procedures too. The probability of somebody taking it was low enough, but it didn't make any sense. I felt more comfortable testing and with the kids at home and everything. Not that we didn't get COVID, but we got it. But still from different resources.
I guess one other point is that aside from just like general GI presentations, we also have like the critically ill patients and all of the complications that come with just being critically ill because of COVID. So oculus cholecystitis, pancreatitis. I don't know if you guys saw that as well, but those are probably pretty common with patients.
Don't want to see your face. Go now. Stay.
So I mean, I didn't see much like pancreatitis. I think that probably was due due to the complications, probably just stress or like all the medications or whatever. I don't know if COVID itself. I'm not aware. At least I haven't seen any in my hospital. But yeah, I mean, it's when they're to that point where I go into the intubated room and it's like, what do you want me to do? It's like, what do you do? Pancreatitis, supportive care. What do you do? It's kind of one of that points where not many patients made it out to that, obviously, to that point, since you guys, everybody's aware. But
that's an easy one to say just supportive care, but then we have patients who have actually ischemic bowel, but then they have rip roaring on ECMO, on this other stuff, and do you take it to the OR because taking out the dead bowel is going to help their other symptoms, or they're just too risk. It was pretty difficult the last more so earlier late last year and earlier this year when we had all these cases, and now it's starting to die down.
Wasn't easy.
It's difficult because then are you really saving them at that point? Is it dead bowel because of it, or is the ECMO because of the dead bowel? It's really sad, actually. The at our hospital, it's probably similar to for you guys as well. We are packed full of patients. ICU got converted to an ICU. Our pre-op area got converted into a PACU and then to an ICU. The only time we were getting availability on beds was when some patient would expire because of family decision to withdraw care after weeks and weeks and intubated or something like that. Very few patients end up coming. So it's, like we discussed, it's supportive care as best you can, and not to they're already hurting. That was a great presentation, by the way, Lorena. Great presentation. Very.
Thank you.
Lorena, great presentation.
Actually, because it was very, very heavy on pathologic stuff, but very relevant to what we're doing, honestly, daily now with patients. We still have even in my community here, we have a huge percentage of non-vaccinated patients. So COVID is still real and running around the community.
Yes, it is. Now we got to worry about Delta variant or whatever variant.
Same here. We're seeing a little bit of an uptick currently.
We should pay the 250K and go to space and just stay there.
Well, I hear that the Delta strain is more GI symptoms. That's how it presents. So maybe we're going to see more GI stuff and more severe, actually.
Oh,
Maybe
boy.
this is the pathology that we're seeing, like the presentation today. It's probably, it's actually good because maybe we're going to need it. Hopefully not. But yeah.
I think it's definitely there's gonna be an increase in cases, especially given that restrictions have decreased, so more people are gonna go out.
I mean, look at the soccer game yesterday. Yeah.
Oh my God.
Yeah, so at least we'll all have jobs.
True that. All right.
All right. Well, great.
Great job, guys.
Great job,
Thank you.
Verona. Thank you so much.
And again, this is first time I'm seeing you and meeting you. I think it's first time for all of us to meet
Yeah.
you. Well, thank you for joining us.
Of course.
And
Yes.
yes,
I'm glad.
we want more
I'll
of
be
you
here.
guys.
Of course. That's what we hear. I'm glad. I'm glad.
I think next month's presentation is going to be GI related too.
Was it diverticulitis or something? Was it?
Yeah.
Is it that?
Oh yeah, it's gonna be
Yeah.
Dr. Chaushai.
Yeah.
That's the plan.
Yeah, you should,
Diverticulitis.
you should definitely attend if you can, because it'll be interesting.
It
Yeah,
will
for
be,
sure.
I think.
Yeah.
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 I just got
For,
I just got back for Aruba, so I'm like, all right, I got to make this presentation.
Good for you.
Well, I couldn't tell it all from the shirt.
Yeah.
Nice. I was jealous. Why?
Yeah, it's not really.
That's the only reason I was paying attention.
Yeah, it was great.
So our actually diverticulitis will be on September. The next journal club will be on August, and it will be Dermatology Journal Club.
Oof.
Very interesting.
nice.
With Dr. Aurora
It's stuff that
Shego.
we know nothing about, so that should be there.
I take pictures and I send it to my dear friend. What is this? A rash?
Well, maybe we'll all learn something. 'Cause
Absolutely.
Agree.
Yes,
Absolutely.
we need to.
Well, thank you again, and hope you have a good evening.
Pleasure, guys.
Thanks,
Thank you.
everyone.
Thank you, everyone.
Thank
Bye.
you.
Yeah.
Good night.
Good
Bye.
night. Bye.